have some thought-provoking, challenging cases in our OPD which make us change. And if the change is conservative, it is always good. So with this insight, we'll move on to the first session and we'll have a series of case presentations. I will now invite Dr. Sahiba to present the first case.
Thank you, Mayank. So my case is going to be a case on an interesting case on my encounter with a new device. So here's the case. This is a one-eyed individual, a 68-year-old male with a vision of CF at 1 meter. On presentation, his IOP was 65 on 2 anti-glaucoma medications. He had corneal edema and one can see there is compromised conjunctiva as well. So his past history was something like this. He says that 1.5 months ago, he underwent cataract surgery. It looked like an SICS wherein a PMMA IOL was placed because I could see the scleral tunnel and the conjunctiva over it. He also says that 3 weeks before presentation, he underwent another surgery after which he couldn't see. It looked most likely a limited vitrectomy for some dropped cortical or nuclear fragments because one could see that there was a scleral port sutured with vicryl over there. So after 2 weeks of intensive medical therapy, I was able to bring down the IOP to 23. He was on maximum medications. Vision had cleared. It became 660. The cornea was clearer now. So now what do we have? We have this patient who's a one-eyed individual. It's a vitrectomized eye with open angles, very, very advanced glaucoma, and a compromised conjunctiva with pseudophakia. This is how bad his visual fields were. So I plan to do an Ahmed clear path in this patient. We've gone over and over the surgical steps, so I'm not going to elaborate. Just a few points that I've only made about 3 to 4 mm incision, and this is a taco technique wherein you completely fold it into half and then tuck it inside and unfold it under the conjunctiva. Rest of the steps will be the same. The eyelets are very easy and anterior to suture. Here the tube is being placed in the sulcus and I'm checking the position of the tube and the ripcord suture is placed subconjunctivally. The patch graft over the exposed part of the tube and then the conjunctiva is sutured with 3 interrupted 10-0 nylon sutures. So on first post-operative day, the patient's vision was 636. His IOP was 6. It was acceptable to me. There was a little bit of inflammation, yes, but the tube was in place. The AC was very well formed and the tube was well covered. Everything was fine. But to my horror, on the third post-op day, I saw that there were massive choroidals, which are visible even on the slit lamp. But there was no leak, there was no overfiltration, there was a very, very mild shalling of anterior chamber, which is probably because of the posterior push of the choroidals, but there was no tube touch with the cornea and the AC was actually well formed. And on B scan, I could see that there were kissing choroidals. So now the next few days were a little bumpy for me. Even by 9th post-operative day, the patient is on heavy dose steroids, cycloplegics, all of that. There was only improvement in the inflammation, no improvement in the clinical or the B-scan findings of kissing choroidals. Pressure was 14. However, the vision was very bad, PL+. Well, at this point, I did a lot of discussion with my seniors, my mentors, and they said maybe you have little time and you might need to drain the choroidals. But honestly, I was very, very scared to intervene for a 4th or the 5th time probably in this patient. So I just waited. But what was I waiting for? You also have to be clear about that. I was waiting to see just a trajectory. Will there be any trajectory of improvement? If there wouldn't, then I would intervene. So by the second week, I could see that the choroidals were receding, but the vision was still not improving. Well, I waited a little longer. At this point, let me take a moment to also say that kissing choroidals is not a medical emergency. There is no permanent damage to vision or your retina that you will cause if you don't immediately intervene. It's okay to wait. It's okay to make a logical plan and then proceed. So by the 20th day, the vision had marginally improved to hand movements. The pressure was 17. You can see the B scan also shows receding choroidals. And by the post-operative day 32, which is almost a month later, is how long it took for the choroidals to settle. There are still peripheral choroidals at this point. Now, the interesting point over here is that all throughout this journey, the AC was very well formed. It was deep rather. The tube was very well positioned. There was no overfiltration, no leak. The bleb was very well formed by the end of 1 month. And by 2 months, I could see that the patient had improved. The choroidals had completely settled. You can see the peripheral retina pictures over here. The patient had an ERM, naturally so he underwent multiple surgeries. The bleb was well formed, IIP was 16, so he had settled by now. And by the second post-operative month, you can see that there's a deep anterior chamber. There's an ASOCT scan also. You can see the orange arrows show the tube and the yellow arrow is the PCIOL. And it was only by third post-operative month that I could have the courage to remove the ripcord suture. The pressure had started to rise by then. It was about 24. And over here, the target pressure is in the very low teens. So I removed the ripcord suture post-operative. This was just done 10 days back. So the pressure was about 22 about a week ago. And the patient is on a combination anti-glaucoma medication. So now one pearl I learned from here. So over here now this was a little confusing because generally when you have choroidals, you expect the patient in hypotony, which means after a device, it's probably overfiltration or it's the leak. Right? You can also expect some perilimbal leaks, which are occult and you can't really clinically see them. But even in that case, you have a shallow AC, you have some anterior positioning of the tube. None of that was present over here. So I think this was one of my mentors who suggested this to me, and I would want opinion of the seniors to actually comment on how true this is. So since my patient was a freshly vitrectomized eye, it's said that in a case like this, if you have choroidals, it's not always it's not always by virtue of the tube. It's okay if it's not overfiltration or leak. It probably could be just because it's a freshly vitrectomized eye. The turgidity of the eye is a little less. So inject some balanced salt solution at the end of your tube surgery in a freshly vitrectomized eye to form that tightness of the globe so that the choroidals don't happen. So this is one take-home tip that I have taken, not ever tried it. Maybe in the future I will. One pearl that I learned from this case to share over here is also exercising prudent management. So we generally have a tendency of jumping and panicking and rushing to do something on the first sight of a complication. So it's okay to wait. It's okay to make a logical plan, discuss a lot with your seniors. A lot of us over here are going to move out of institutes and you're probably practicing individually. Take a lot of guidance, but many a times you will be in a situation where only you have seen the case and only your call will be the final call. So make that with a sensible, a clear and a non-panicky mind. And in this case, I think it was a blessing in disguise that I waited in spite of being advised against it, because only I had seen the case. So it's okay to wait and make a logical plan. Thank you so much.
I think we can take a couple of questions because then it becomes difficult to go back to the previous question.
So, do we prefer MFClear or AGV? Because if AGV has valve, so that it might click valve.
So I would request, if it is, we will answer that question, but if it is pertaining to the case, then it will be good. Otherwise, there'll be a lot of questions. Why this, why that? Yes, which is possible, but yeah.
Dr. Saiban, the V-scan looks like an hemorrhagic choroidals. So the probable diagnosis is a delayed suprachoroidal hemorrhage, and this must have occurred due to a transient hypotony. But I totally agree, usually a delayed suprachoroidal hemorrhage will also be associated with pain and shallow ACs. So it's a little different, but what I can make out is a transient hypotony. Pressures were very high preoperatively, no?
Yes, before the surgery was 23.
So high myopes, children and vitrectomized eyes are prone for delayed suprachoroidal hemorrhage, and usually vitreoretinal surgeons always ask us to wait for 1 or 2 weeks because the clot has to lyse before they can drain.
So I would understand why you would think this is a hemorrhagic choroidal. It was done under very low gain.
So I think the B scan is a little misleading, but also when you see on the slit lamp examination, it's very yellow. So it was very much a serous choroidal only, because on subsequent B scans also you could see that low echoes within the choroidal space were not there. It was just on that enlarged image that you could see it felt like it's a hemorrhagic choroidal. It was a serous choroidal. My point, I think, of discussion at the end of this would be is, has anyone tried injecting BSS after a tube implantation, or maybe even trab at the end of in a vitrectomized eye, or would you recommend it? Because that's the advice I got. So even before trying it, another case, I would want some expert advice on this.
So being anterior segment surgeons, I would still prefer that we keep it tight by hydrating the anterior chamber rather than going into the vitreous cavity.
Yeah, so a couple of points that I would like to give is it's a very well managed case and you were lucky and patient was lucky that it resolved. But my take is slightly different. When you have a kissing choroidal, it means that it may not cause a permanent damage if it is very short-lived. Otherwise, what happens is the CD will resolve because it is likely to resolve if there is no leak and if other problems are taken care of. But retinoretinal adhesions that you develop because of a kissing choroidal, which is there for a little longer time, let's say beyond 3 or 4 days, can lead to permanent problem, and you can develop when their CD recedes and the retina is trying to separate, the two adherent retina is trying to separate, it can form a break. And if you have a retinal complication in an eye like this, you have to forget about taking care of that eye. So it's very, very difficult to treat those patients. So yes, I totally agree with you. To start, don't jump and do the drainage on that day. Put them on high dose oral steroids, and of course, always rule out a leak. So one point in this, I know you are experienced and you are taking care, but if I were to do this case, conjunctival closure, I would be very, very meticulous in closing. Pre-interrupted sutures with nylon, I would be very skeptical because yes, you showed the bleb is formed very well, the conjunctiva is healed very well, but so I would look at that if you even a minor amount of leak in that early post-operative period could have precipitated it. On table, even if you make it tight, suppose you have a leak, let's say on a bandage tie, you have a leak on the day of surgery. Once a hypotony occurs and after that you have a CD, it's going to take time for it to resolve. So these are two things that I would say. So give medications, give oral steroids, wait for 2-3 days, see what is happening. Of course, you will see them more frequently. B-scan is very, very useful. And if things are resolving, like you have large CDs, but at least those retinoretinal adhesions or two mounds of the choroids are not really attached to each other, then it's definitely okay to wait because majority of them resolve and you don't have to go and intervene. But yeah, well managed, but a couple of points. And going and injecting the fluid into the vitreous cavity, I mean, vitreous, whether the fluid is there in the vitreous or in the anterior chamber, your outlet is only the tube because it's not vitreous, so it's fluid only. Fluid also is going to come anteriorly and drain. So whether you're filling the anterior chamber by tightening it anteriorly or posteriorly, it doesn't matter.
This is a 2-chamber eye. Does that
It
not
will
count?
no, it is never a 2-chamber eye. Through the zonules, fluid will always reach the front of you. It will never.
And it's already
In a sclerophakic eye, it will always.
it's already a vitrectomized eye. Just question why reason for a conventional trap over a ACP?
No, the conjunctiva was scarred and it was a previous SICS wound. So that's why I said, so whether we can do an AGV or an ACP, I don't think that we should discuss. We should discuss about this complication. I mean, each person's choice is different. Somebody would go and do a supraornasal trap, somebody would do an AGV, somebody would do an ADI. That's okay. That's, I think, the surgeon's preference. But when you encounter a problem or a complication like this, the idea is when you see something like this, should you go ahead and drain it on day one, or is it okay to wait? And the question that Shavna asked is, should you inject the fluid in the vitreous cavity at the end of surgery in a vitrectomized eye because the globe is not tight and you have just fluid filling in there. So at least none of us have done that.
Yeah, maybe.
Yeah.